Okay, so I get a feedback from your class rep, Gregory, and he is telling me that you people can hear me clearly, but because they have unmuted or they have muted all of you, you cannot unmute for you to respond. And this is the first time because of the gravity of the noise that comes from your side. Some people will join from so much noise background, and he disturbed everybody on the platform. This platform is just like you are in a classroom, that everybody is listening to the lecturer. Initially, before we started with your seniors who are in level 400, students can mute and unmute because when you are teaching, students may wish to ask a question and you to provide the feedback. But looking at the nature of the noise some of you make at your background, the number of cautions we have issued to you to mute your microphone, you will not mute it. So these things go a long way to disturb the lecture process, and the reason why they have automatically muted all of you. And I don't think this is a very good reason for teaching and learning, because as you teach, students are supposed to ask questions for feedback. So if we should allow you to mute and unmute yourself, we cannot even proceed with even a single lecture, because the noise that will come from your background, we can't teach anything. So this has become possible because of your attitude. Because anytime we sound caution to you, you disobey it. It's a simple instruction. As you join, mute your microphone. So simple. But some of you will join from the funeral background, and you can imagine the funeral background. Some of you will join in a vehicle, in a car moving. Some of you will join in the market, buying items. Some of you will join at the kitchen, preparing soup or meat or food. Some of you will join from wedding ceremonies. How can we teach in this environment? How? So this has become possible because of your actions. And because of that, they have muted everybody, including me. I have to call the IT unit for them to give me the opportunity to become co-host. So they only allowed me to be the co-host. So I can unmute myself and mute myself. But for you as students, they have not, because of the background. I can only tell the IT people to make the class rep a co-host again, so that Gregory and maybe Edward the two of them can help in case there's, or you can use the chat platform and chat all your questions there. I think that is another alternative that you can use. So chat anything that you want to ask, chat at the chat column. There's a message column you can pass your grievances there so that we can address it for you. And this is possible because of your the way you manage your mute and unmute backgrounds and the noise that disturbs the lecture. So we'll handle it like that. I think it's a very good process. It makes the lecture period very serene and quiet, and I can teach and ask questions for you to give me or for you to ask whatever you want to ask and supply what they needed answers to you through the chat box. So without wasting much time, already the IT people have wasted almost 20 minutes, and I was calling everybody there to make me the whole co-host. So I wouldn't waste much of your time. We can start with the course content. I have already sent the course content or the course outline to your class rep, Gregory. And I've told him to share to you all the class reps from the various centers. We are joined by students from Tamale. We are joined by students from Tamale, Wa, so Tamale Center, Wa Center. We have Koforidia Center. We have Akemodan Center. We have Keita Center. We have Asankregua Center. And the last but not least is Kumase Center. So these are about 8 centers. And every center has class reps that have joined this lecture. I learned Kumasi lecture is Gregory and Edward. Is that true? If it is true, I would like to know. Gregory just called me. I don't know about Edward. So as we move on, we will get to know the various class reps and pass messages or information across. So we can move on like that. All right. So that is the information out there. And we are going to do medical nursing 1. And the credit hours is 2. That's my information over here. So we have the course description. We are saying that this course that you are going to handle, the medical nursing 1, is going to provide an integrated approach so that you can do very good assessment for client with fluid and electrolyte balance or imbalance, gastrointestinal, patient with gastrointestinal disorders, endocrine issues, and renal systems. So this equips these students with both theoretical knowledge and practical skills that you will need to perform accurate patient assessment and evaluations. So when you are at the hospital and clients come to you with dehydration or overhydration, client comes to you with disturbs in fluid balance, you should be in a position to do good assessment and come out with your diagnosis and interventions. So that is why you are doing this course. You also have to do good assessment and diagnosis for patients with gastrointestinal disorders, endocrine issues, and renal system issues. So you need both theoretical and practical skills to do these things. And we play emphasis on understanding normal physiology because you need to understand. I need to frankly tell you that you need a lot of physiology to understand what you're going to go through, especially the fluid and electrolyte imbalance. You need information from biochemistry, physiology to understand fluid and electrolyte imbalance. It's full of physiology and biochemistry. So you need to pay attention. So you can identify deviations from normal functions. For example, patient with severe dehydration and patient with severe fluid volume excess. So you can recognize common clinical manifestations and interpreting findings to support early diagnosis and holistic nursing care. This course also highlights the interrelationships between these systems in maintaining homeostasis and overall health. So once you are able to get adequate knowledge from these systems, you will be in a position to make sure that any patient who comes to the hospital will at least achieve a normal fluid balance, in which case the patient will not be either fluid volume deficit or excess. However, you would also need this knowledge to assess other conditions coming from endocrine, gastrointestinal, and renal functions. so you can adequately manage these patients very, very well. So our core objectives is that by the end of this course, you should be able to explain the anatomy and physiology of the gastrointestinal, endocrine, and renal systems, as well as the principles of fluid and electrolyte balance. Demonstrates appropriate assessment techniques, including history taking, physical examination, and laboratory interpretation relevant to each system. So each system we are talking about fluid electrolyte, gastrointestinal, endocrine, and renal systems. Identify normal versus abnormal findings in fluid electrolyte balance, gastrointestinal, endocrine, and renal assessment. Recognize clinical signs and symptoms of common conditions such as dehydration, electrolyte imbalance, peptic ulcer diseases, diabetes mellitus, thyroid disorders, acute kidney injury, and chronic kidney diseases. Accurately document assessment findings using professional nursing terminology. Integrate assessment data from these systems to develop comprehensive and patient-centered care plans. Apply critical thinking and clinical judgment in prioritizing patient needs and planning appropriate interventions. So these are our objectives we want to achieve by the end of the course. So we need one. The first, we are going to look at physical assessment of clients with fluid and electrolyte acid-base imbalance, overhydration and dehydration, isotonic, hypertonic, hypotonic, heat stroke, solute excess, solute deficit, metabolic acidosis, alkalosis, respiratory acidosis, alkalosis, fluid electrolyte balance, edema, dehydration, acidosis, alkalosis, preparation and demonstration of intravenous therapy. We'll look at how you prepare and administer IV therapy. In which case do you pick ringers? In which case do you pick normal saline? In which case do you pick DNS, dextrose 5%, 10%, and so on? What informs your decision in selecting these fluids? What are their compositions based on the changes within the client's biological systems? So we look at causes of fluid electrolyte imbalance. What are the causes? Causes of acidosis and alkalosis, both respiratory and metabolic. Then we look at features of dehydration, in which case we are looking at signs and symptoms or clinical manifestations of dehydration, overhydration, electrolyte imbalances, and acidosis, alkalosis. Compensatory mechanisms associated with isotonic and hypertonic dehydration, risk factors for dehydration. After the signs and symptoms, we look at interventions for clients with fluid and electrolyte urine taking, vital signs checking, breath sounds hearing, muscle weakness assessment, CNS assessment, including mental status, hyperplasia, tetany, both chivosics and transosine, cardiovascular system analysis. We look at arrhythmias and decreased cardiac output. Then we look at diagnostic tests for serum levels, urine, pH, specific gravity, blood urea nitrogen, arterial blood gas, anion gaps. Then we look at hemoglobin and hematocrit. Then we look at the nursing care that will be given to patients in terms of oral rehydration therapy, therapeutic diets, blood gas interpretation, positions we use to care for these patients, whether semi-fowlers or high fowlers, respiratory, oxygen 10 caps, deep breath, in-central spirometry, oral hygiene, infusion therapy, and health teachings. Then we look at infusion therapy in details. Here we look at infusion systems and containers, administration sets, nodeless system, infusion regulation devices, types of infusion therapy, intravenous therapy, both peripheral devices, descriptions, and short-term and long-term dual catheters. Central intravenous therapy, then we look at devices. Non-tunnel central venous access devices, implanted ports, common intravenous maintenance procedures, complications of intravenous therapy, arterial therapy, description devices and complications. Intraperitoneal therapy, that is fluid that is going through the peritoneal cavity. So we look at description devices and complications. Then we look at how to give fluids at the subcutaneous area. So here we look at description devices and complications. Then we look at central nervous system therapy, where we look at epidural therapy, intrathecal therapy, description, devices and complications. Then we look at intraosseous therapy in between the bones, and description, devices and complications. The introduction of peptic ulcer diseases, that is for GIT conditions, gastric esophageal reflux disease, that's the GERD, achalasia. We have intestinal obstruction, Zollinger-Ellison syndrome, irritable bowel diseases. All these are GIT conditions. From unit 8 coming down is GIT conditions. Then we look at appendicitis. Appendicitis can be looked at the medical aspect of it, peritonitis, ulcerative colitis, Crohn's diseases, and hemorrhoids. Initially, the surgical aspect, we look at the hemorrhoidectomy, then appendicectomy for the surgical aspect, and then maybe laparotomy for GIT interventions. Diverticulitis, anal fissure, fistula in ano, all these, the surgical aspect will take care of it. Malabsorption syndrome, hepatitis liver, cirrhosis, hepatocellular failure, and hepatic coma. Cancer of the liver, liver transplantation, fatty liver, and cholecystitis. Then we look at pancreatitis. So we handle our midterm. The midterm week will be communicated from the university. So we go by that. Whatever we have reached, we will handle our midterm. That will be on virtual. So we use the portal. The questions will be uploaded on the portal for each and everyone to be able to access during the midterm. And that will be for 30 marks. Not only that, the midterm can take about 15 marks. Then we have quizzes and assignments for you to do. Everything will be uploaded on the portal so that when it is time, you can access it and do it and submit it. Then we have the unit 14, we have the hypopituitarism, diabetes insipidus, syndrome of inappropriate antidiuretic hormone, that is the SIAAH, that is the syndrome of inappropriate antidiuretic hormone. Diabetes mellitus, the unit 15 talks about Addison diseases, Cushing syndrome, adrenal gland hypofunction. Unit 16 talks about renal failure and nephrosclerosis. Unit 17 talks about nursing care of a patient undergoing peritoneal dialysis and diabetic nephropathy. Unit 18 talks about diabetic foot nursing care of a diabetic patient undergoing surgery, orchidopathy, orchidectomy, and we have unit 19 talking about diabetes ketoacidosis, also known as the DKA. So our assessment and evaluation is 30/70 for the continuous assessment and end of semester assessment. Then we have reading materials for you. These reading materials, everything will be sent to you at the end of the day. I've already sent the course outline to your class reps, and he will distribute or share it to you accordingly. Okay, so at this point, I have finished taking you through the course content. I would want to ask if you have any question on this, but whenever I ask a question, you can't give me direct responses because of the nature. Yes, I think I have seen Opoku Frank Ajeman. Yes, he was asking a question. Is the MSM going to be objectives? What the answer? Yes. Whether objectives, whether theory, whether case scenario questions, whatever you have to embrace is the questions is there for you to go and solve. Definitely, you will know the nature very soon. I've told you it's not going to be one particular aspect. We will do quizzes, case scenarios for you to submit your answers on the portal. So if you go there and it's a clinical scenario, you just look at it, answer it, and submit your answers. You understand? What the other saw, ma'am, that's all. Your objective, so you're feeling no, so your case scenario, whatever it is, no matter the nature of the question, you should be in a position to answer it. That is how I want to respond to this question. I won't tell you subjectives. So you relax. You ask for A1, B1, C1. No, you are doing a BSc nursing and you should close the gap between the diploma and then the university. So you should be in a position to assimilate and respond appropriately. That is it. No spoon feeding. You must read other materials. I'm going to send you a lot of materials, not only one material for you to read. I will send the slides to the class rep and he will share it for you. But you can also read other books. All right. Thank you very much. If you have any other question, you can use the chat box and chat me. So I can respond appropriately to you in the chat box. Yes. Mensa, you've raised up your hand. You can't talk. You can only chat. Then you can only chat. You can't talk. Mensa, let's hear you. So I want to start teaching, but if you have any question on the course content, you can let me know. But you have raised up your hand, even though I have not started teaching anything. Let me hear from you. Yes. I was sharing a slide, so I have not started teaching. So if that is what you are asking, then I'm now going to talk. So when we talk about fluid volume deficit, we are talking about a situation where water and electrolyte are lost in the same proportion as they exist in the normal body functions or systems. So that at the end of the day, the ratio of serum electrolyte to water remains the same and unchanged. Remains the same and unchanged. So this explains that, yes, Anthony, Bossman, yes, you free up your hand, let's hear you. I've told you to chat because they will not allow you to talk. So chat and I can respond to you. So if you raise up your hand, then you can chat. So I can at least respond to you. Yes, Bossman, is there any problem? Your hand is up. Anthony Bossman. Your microphone is muted. You can only chat within the chat box for us to know whatever you want to ask. Okay. Until you do that, we can go ahead. So, assuming you have a container with both water and electrolyte, or let us use another person's hand is up. What is happening? Please use the chat box. Let me call Gregory. General issue, what is it? What is general issue here? He's not talking, Anna. Why? Let me make the let me call the IT people to make the reps the co-host so I can respond to them. Me, I can't do anything. No, I only call for them to change something for here. I am not controlling the whole thing. It's control from the IT unit. So to make you the co-host, I don't have that power. I only call them to do it. I don't know. Let me just call it right now. My volume is 100% too. My volume is 100%. Maybe check your network area. Yes. So I have asked the IT to make Edward Anane and Gregory the class reps, the two class reps, the co-hosts, so they can also communicate whatever is going on to me directly. But for the volume, I have raised my computer, my laptop volume to 100. So I don't know if you still can't hear me. I don't know. I don't know. So let's use the body as a system. If you lose 20 mils of water, then you lose, in addition, 20 grams of salt. So at every point in time, the ratio of water to solute remains the same. That is what we are talking about, fluid volume deficit. So here, the proportion of losses. Okay, so if you use the body as a container, or if you consider the body as a container, we have both solute and fluids or water. So we are saying that for you to lose the same amount of electrolyte and water, meaning that if you lose 20 mils of water at every point in time, you are losing 20 grams of salt at the same time. So that at each point, the ratio of serum water to electrolytes will remain the same. There will be no change. And when we talk about the FVD, this is a decrease in intravascular and interstitial fluids. And this is a very common and serious fluid balance that results when vascular fluid volume loss is excessive. We call it hypovolemia. Now you can see. Now you can see. Yes. Somebody was muted, and this is the sound coming from the background. And this is how, if we make all of you, your microphone to be unmuted, this is the kind of noise we are going to hear. So this is an example. So now Gregory has been made co-host, and I think, is it Veronica? So host, co-host. So the co-hosts are two. I'm seeing Veronica and Gregory. I'm seeing the two of them. Okay, so now you people are the co-hosts for this lecture. So you can speak on their behalf. So before I continue, let me get to the chat box if there's something there. Okay, so
I want to ask a question.
Okay.
I wanted to ask, when we're speaking about the fluid volume deficit, you made mention of losing both fluid and electrolytes in the same proportion. And I'm asking, please, can there be a situation whereby fluid and electrolyte cannot be lost in the same proportion? And how do you term that?
But I have not spoken about anything. I just started.
Okay.
Hold on with your question. You will understand.
Okay.
This is just a piece, about 2-3 sentences. Maybe by the time I finish explanation, it will be clear to you.
Okay. Thank you.
Yes. I'm even going to explain further, but because of the co-host issues, I paused. So we are saying that we have systems, we have compartments, and one compartment is intravascular compartment, another one is interstitial compartment. Intravascular compartment, we are talking about the blood vessels, the blood volume. The blood vessels contain the blood. And anytime you lose fluids, you start losing them from the cells and finally from the intravascular volume. Then we have interstitial in between the cells. So you lose fluids first from the cells, and then secondly from in between the cells, then later from the intravascular space. So when we talk about a decrease in intravascular, then we are talking about decreasing fluid from the blood vessels. The blood vessels contain blood, and the blood has both cells and plasma. So the plasma portion contains the fluid or the water, and you lose fluids from these areas. First, you lose them from the cells, and secondly, in between the cells. Oh. Now you can imagine what I was telling you. Somebody should be cutting contumely, so she's at the kitchen, and she's disturbing the whole class. Disturbing the whole class. So it's like you are in a classroom and somebody pops into the class and start talking about cutting contumely. Disturbing everybody. So I have muted everybody. And if you want to talk, you are mute. So now, a decrease in intravascular and interstitial fluids. So you lose fluids from the blood vessels. So any fluid, any blood found within the blood vessels is called intravascular. So fluid are lost from these spaces. Then they are also lost from in between the cells. I will show you a slide that talks about the cells. And once you lose fluid continuously, it can lead to hypovolemia. Hypovolemia is when blood volume goes down below the accepted figure. And that is where compensatory mechanisms set in. So fluid volume deficit can lead to cellular fluid loss or to fluid shifting from the cells to the vascular space to restore blood or fluid volume or fluid balance. So anytime you lose fluids, you lose them from the cells, then from the blood vessels. Let me share a slide to you so I can use that to explain about the movement of fluids. Okay, so we have For males and females, we have the total body water for females. We have 45 for cells and 55 for fluids. So that is for the females. And the males, we have 40 for cells and 60 for fluids. So in terms of fluids, the males have more fluid than the females. And in terms of cells, the females have more cells than the males. Now, if we come to the fluid portion, we have the intracellular that has about 2 tests ICF. Intracellular fluid, they have 2 tests. We are talking about the plasma portion. Then we have extracellular fluid, also contains 1/3. So as talking about the plasma volume, we have both intracellular fluid and extracellular fluid. Intracellular fluid, extracellular fluid. So these are the 2 major compartments, and they all form part of the plasma. If you talk about the extracellular fluid, we have the interstitial fluid taking about 80% of the extracellular fluid. And then we have the plasma that takes about 20%. So here, the interstitial fluid you are talking about in between the cells, and other body fluids will take the rest. I'll further give you the explanation. These are all the percentages we are talking about. So these are the proportions or the fractions when you talk about the plasma volume. So if you take the plasma volume or the total body water, we have 65% of the fluid found within the intracellular spaces, within the cells, and they constitute 2/3 of the body water. In terms of fraction, it is 2/3. In terms of percentage, it is 65% of the total body water found within the cells. Then the next higher percentage is found within the interstitial fluid. So the interstitial fluid is in between the cells, and they constitute 25% of the total body water. 25%. Then we have the plasma. The plasma talks about the intravascular. So if you hear plasma, don't get confused. It's still talking about the intravascular, because the intravascular that contains the plasma and then the cells. So the plasma talking about the intravascular has the 8% of the total body water, and we have the next 2% with the transcellular. So the transcellular fluid talks about the interosseous, the intrathecal. All these areas constitute the transcellular fluid. Those fluid in small spaces takes about the 2%. So that's the total body water. So as you shift fluids from the body, the fluid starts moving from the intracellular space, that is the 65%. Then it comes to the plasma, which is the intravascular, or comes to the interstitial, then the plasma. So you lose fluid from these spaces. Starts from the intracellular, interstitial, then the plasma, before fluid comes out. So that is how people lose fluids or body fluids. So when I talk about intracellular is within the cell. That is where fluids start moving from. So when it goes to the advanced stage of fluid loss, the patient will start complaining that I feel pulling. That's the feel language. I feel crampy pains within my body. It means the cells are shrinking. The cells are collapsing, plasmolizing. That is the advanced stage, complicated dehydration. So it's another division here That makes it clearer. So we talk about the total body water. We are talking about the intracellular fluid found within the cells. From books to books, the percentage can change, but the fraction remains 2/3 of the total body water. Aside the intravascular or intracellular fluid, the rest of the fluid belongs to the extracellular compartment. It is the extracellular that we have the interstitial fluid, then we have the intravascular fluid, then the rest of the fluid, which is the 2%, will form the lymph, the transcellular. So the transcellular, everything is found within the 2%. So these are the total body water. So understand so that you appreciate how fluid moves. All right. So we have two major forms of fluid volume deficit. There are two types. So somebody initially raised the hand in order to ask a question. And we have two major types. The first type is hyperosmolar fluid volume deficit, in which case the fluid loss is greater than the solute. So at every point in time, if you lose more fluid than the solute, then you are losing fluid in greater quantities than the solute. So what is left behind within the body is more of a solute. So it makes the concentration very, very high because we are talking about dehydration where fluid has been lost in excess of the solute. So here we call it hyperosmolar. Hyperosmolar. Let me add the mobile. And almost a year one crack. Na meka na ɔmo kɔ nti mehwɛ sɛ ɔmo betumi abɛduru na yɛbɛtumi ahyia ɔmo nyinaa na ɔmo wɔ hɔ sisi a me ne wo kasa yi sɛ yɛ maame nua baako afirim nti Rosemary koraa kɔ bi yɛ last born.
Ba usaha sasa. Ele apoia isso.
So we have hyperosmolar fluid volume deficit. Here we are talking about loss of fluids, or when you lose fluids that is in greater quantities than the solute. The solute here referring to sodium. So at every point in time, what is left behind is the solute, which will make it more concentrated. So we talk about hyperosmolar. Then another situation is where both the fluid and the solute are lost in equal proportion. In this case, we have isoosmolar or isoosmolar fluid volume deficit. Isoosmolar fluid volume deficit. So that is the two deficits we are talking about. So either isoosmolar or hyperosmolar. The isoosmolar is when you lose both solutes and the fluids in equal proportions. Then the hyperosmolar is when you lose fluids in greater quantities than the solute. So at every point in time, what is left behind is more of solute, making the concentration very, very high. Now, the person who raised the hand to ask the question, now let's hear you. You were asking whether patient or the body can lose water, whatever. And I want to know your question now. Or you are okay with these explanations? I told you to hold on because I have just started. And as I move on, you'll be able to understand. Now, per this explanation, do you understand or you still have a question to ask so I can move on?
Yeah, now the understanding is clear.
So I told you to wait. You understand? Yeah. Okay, let's move on.
Okay, thank you.
All right. Let's look at the causes of fluid volume deficits. We are talking about abnormal fluid losses, so not just any fluid loss. You can just lose some small amount of fluid and the body can recover from that. But when you have abnormal fluid losses resulting from severe vomiting, somebody can tell you, I have vomited 5, 6, 7, 8, 9 times the night before the daybreak. It's abnormal fluid loss. Gastrointestinal suction at the hospital, they might be using other instruments to suck a poisonous substances from the GIT to prevent it from being absorbed. And this suction may lead to abnormal fluid losses. Excessive sweating. Some people can work under the scorching sun and they'll be sweating severely, excessively. And this can lead to sometimes even after sweating, when the person's body dries up, you can see some white crystals on the person's skin. It's telling you about the salt that dries on the person's skin. So it's also a form of losing so much fluid. And the person can be termed as hyperosmolar because at that point you may be feeling so much thirsty that the body tells you that you need to drink to replace the lost fluid. The first sign for you to know that you are dehydrated is thirst. The thirst mechanism will be stimulated for you to drink more water. Once you become thirsty, the understanding is that you have lost more fluid than the solute. So take in more fluid to balance the solute within the body. We have diarrhea states. The person may inform you at the hospital, I have passed watery stools 5 to 6, 7, 8, 9 times the day or the night before the daybreak. And this tells you how severe the fluid loss is. All this can lead to fluid volume deficit. So here, this condition can develop rapidly or can be also mild or moderate or very, very severe, depend upon the degree of fluid loss. Acute weight loss can be a sign of fluid volume deficit because the amount of fluid within the body determines your weight. If you have more fluid, you have increased weight. If you have less fluid, the weight is also less or decreased. So if you have less fluid or dehydration, your weight is going to be affected negatively. So you have acute weight loss. If you have acute fluid loss, it reflects the weight loss. Decreased skin, you yourself can feel it. When you lose so much fluid, you can feel within your body that you have lost so much weight. Decreased skin turgor. Sometimes when you hold your skin and you pull, the skin becomes inelastic. Then you feel oliguric. So oliguria means the scanty urine. Sometimes if you are dehydrated, you will never feel the urge to maturate. Once you start taking in fluids or water, then you start having the urge to pass the urine. So that is Dehydration state, you feel oligoric. That is, the scanty amount of urine will be passed, concentrated one. Okay, you have postural hypotension, and this explains that once you change in position, you start feeling dizzy. And you feel dizzy because the cardiac output is low in terms of dehydration, because the amount of blood that is circulating throughout the body is very, very low. And it is low because you have lost so much fluid, because we have the total body water that is found within the blood is about 60 to 65%. And once you lose water, you lose blood. And once you lose blood, and when the heart pumps the blood, it may not be able to give you good circulatory volume. And because of that, once you change position from sitting up to standing position, you feel dizzy. And once you feel dizzy, it tells you that you are experiencing hypovolemia, low blood volume in circulation. And that is one of the signs, postural hypotension. The weak rapid pulse is a compensatory mechanism that the body is giving the heart a feedback that we are not getting adequate circulation. So increase the rate at which you pump blood to circulation. And once the heart increases the pumping action, definitely it reflects as weak pulse, and weak rapid pulse is a sign of a compensatory mechanism during dehydration states. Diagnostic investigations here, we do laboratory investigations. Yes, Veronica, you've raised up your hand. Let's hear you.
Sir, please, how is it going to cause the skin tear?
Yes, the skin will be inelastic, the skin will be flaccid, the skin will be dried up because of the dehydration. Once you lose fluids, the skin becomes inelastic and loses this turgidity. And I may show you a slide. If you pull the skin remains up. It doesn't come back easily, and that is a sign of severe dehydration. So let me share a slide for you. Maybe it's found in this slide. Okay, so you will see this slide. You see the patient lying flat or lying prostrate, and this shows that the patient is severely hypovolemic, and the patient cannot even stand because of severe hypotension, severe postural hypotension. The patient cannot even stand, so he's lying flat, and that tells you there's postural hypotension. Postural hypotension. So he's lying flat because of the hypovolemia. If he stands up, he will fall or he will collapse. So that is one of the signs of dehydration. Then I think this is the severe and inelastic skin. So you see that once the person pulls the back of your hand, the skin remains high, it doesn't fall flat. So this shows that this person's skin is severely inelastic and dried up. It's a typical sign of dehydration, and medically or clinically, we use to diagnose patients at the hospital. If you want to find out the state of dehydration, we use to pull the back of the hand or the skin, and once it remains high up, it shows the extent of dehydration, the extent of dehydration. So that is the fluid volume deficit. Okay. and that is oliguria, concentrated urine, postural hypertension, weak rapid pulse rate, flattened neck veins, increased temperature, because most of the children, once the temperature is not dropping, you see that they are dehydrated. Once you start putting on the normal saline or whatever infusion, then the temperature starts resolving. So one of the signs while periods of children temperature remains high, check, it could be severe dehydration. Then decreased central venous pressure because of the low fluid volume. Somebody hand was up. That is who? Mary Pakuma. Yes, your hand is up. What is it? Let's hear you.
Yeah, good afternoon, sir.
Afternoon.
Please, I have a question about the clinical manifestations, the acute weight loss.
Yeah.
Please, a patient that's, let's say you are the OPD and then the patient is brought in. This is a patient maybe you've never seen, so you don't have an idea how, the weight or, how the person looks. So how do you get to know that the patient has lost weight? Yeah, please, that's my question. Because I'm saying that because that might be my first time meeting the patient.
So what is
How?
the best way of assessing weight? Don't you have the weighing scale? Weigh the person. Can you use your eye to gauge the person's weight? You have the weighing scale. Weigh the person and get the weight. So is that a problem for you? Mary, is this a problem? If you
No.
want to get the patient's weight, can't you weigh the patient and get the weight?
Yeah, I understand that we can do that with our weighing
So
scale.
what other way do you want it?
I was asking because my point was that this is a new patient that has come to visit us at the facility, and then we have no history or we don't have any idea. We don't have any idea his past weight and all that. So that was the reason for my question, please.
So you check. You take the weight. It's part of your assessment.
Okay.
Right? Yes, it should be part of your assessment. First weight taking is part of your assessment. The vital signs and everything, you take the weight and you record. And that should be the baseline for subsequent comparison.
Okay. All right. Thank you very much.
All right. Yes. If you, I will give you, write your question down. The last 15 minutes will be left for question. Otherwise, I can't finish to you yourself will be the first person to say the content we didn't finish. Write your question down. I'll give you time for you to ask your question. Otherwise, I can't move on. Okay, please let's continue. If I allow you to be asking questions, I can never proceed. Write your questions down. When I'm about to finish, I will leave time for you to ask all your questions and I can explain them to you. So diagnostic investigations or evaluations, we are running the blood urea nitrogen and creatinine levels in relation with the serum creatinine. So concentrations here, we are saying that once you lose fluids, the body is compared to a gutter that is dried up with rubbish. In dry season, you will see that gutter becomes dried up and there are so many rubbish found within the gutter. So the gutter is choked and becomes so much dirty. And that is highly compared to a body which is dehydrated. When the body is dehydrated, you have so much waste that is trapped within the body. And once you have a heavy rainfall, the rains flashes everything, and the next day you see the gutter become becoming so clear and nice. So anytime there's dehydration, the body's waste, which we know urea, nitrogen, creatinine, increases. They increase, and that tells you that the body is having less fluid to flush these waste for the kidney to clear. So once you have dehydration, then estimate that the body waste is going to be high. And once the body's waste is going to be high, it can affect and cause problems to the body. Hematocrit level is greater than normal as the red blood cells become suspended in the decreased plasma volume. Of course, the hematocrit and the hemoglobin are different. Those who have worked at the pediatric ward before, if they want to put on a blood transfusion to a client who is pediatric, what they do is, if they want to really assess the real hemoglobin level, they don't take the hemoglobin, they do the hematocrit. And the hematocrit is that they use the micro test tubes, put in the blood, seal both ends, put these micro test tubes on a centrifuge machine. Then they will centrifuge this machine for them to separate the plasma from the cells. And the amount of the cells really tells you the actual level of the person's hemoglobin values. So once you have the centrifuge machine separating the plasma from the cells, then the cells alone without the plasma is considered as the hematocrit. And the hematocrit levels are the very good criteria for assessing a child hemoglobin status. And that will determine how much blood and which type of blood transfusions we even put on. Will the child need a whole blood, or the child will need the packed cells? It will inform all these decisions because the level of the hematocrit will determine whether the child will need the total or whole blood, or hematocrit readings will determine whether the child will get only the packed cells or the whole blood. So it's a very good criteria when determining the fluid status at the pediatric ward, and even the blood level for children in terms of blood transfusion. But in dehydration, the hematocrit levels are always greater because the plasma volume is always low because of dehydration. The fluid portion is highly low, and therefore the hematocrit level, which are the cells, are going to be higher than the fluid. So how do we manage these cases? How do we manage them? So usual maintenance requirements: if there's fever, you have to treat the fever to make sure that there's no fever to interfere with this dehydration. When the deficit is not severe, we look at the oral routes, then we give the ORS. We have so many things that we can give when the patient is not vomiting and can drink adequately. We prefer the oral routes. However, if the patient is vomiting, then we look elsewhere and get the IV routes. So these are the things you have to consider first. What is the extent or the level of the dehydration? Is it mild, moderate, or severe? And is the patient vomiting or not? If the patient is not vomiting, then the oral route is preferred. If the patient is vomiting, then we have the intravenous route assessing it for the patient to use. Then we can also put isotonic electrolyte solutions such as lactate ringers or 0.9 sodium chloride is preferred. Here to use the either you use the normal saline, which is the isotonic electrolyte solution, or the ringers lactate. We can use the two solutions. We call them blood expanders for dehydration. So once the patient is dehydrated, you can either combine interchangeably the ringers lactate and the normal saline. The normal saline is also known as isotonic electrolyte solutions. So also the ringers lactate contains the lactate and gives instant energy to the patient. So as soon as the patient, once you put on these fluids and the patient becomes normotensive, so how do you ensure the patient has become normotensive and therefore you need to change the fluids? You can use it by using the normal intake and output chart. So once you use your intake and output chart, you'll be able to know that this patient intake is equal to the output, and therefore the patient has achieved a normotensive state. As soon as the patient reaches the normotensive state, then you have to put on a hypotonic electrolyte solution. Hypotonic electrolyte solution contains 0.45 sodium chloride, and you put on this infusion and it flushes the waste from the kidneys. So anytime patient becomes dehydrated, we have so much waste trapped within the system, the renal system. So what we anticipate is that after achieving normotensive, you increase the renal fluid so that urine production can wash and flush all the waste away. And we use this by putting on hypotonic solution of 0.45 sodium chloride so that these fluids will flush the waste from the body, and the waste will not be accumulated inside the body. So anytime the patient goes through severe dehydration, mind you, once you get the normotensive state, always use the 0.45 normal saline hypotonic solution to flush the body of its waste. So here we are talking about movement of fluids. Please excuse me. So here we have containers that determine the direction of fluids. So if you look at the first container, you have the first container on your right side, you have less solute, and on the left side we have more solute. So we can define movement of water when we are defining osmosis. So osmosis can be defined as movement of fluids from a region of lower concentration to a region of higher concentration. So here the fluids are going to move from the lower concentration to a higher concentration. So where we have the lower concentration, the solutes are less and the fluid are more. So that is where fluid will move from that area to a concentrated area. So that is in terms of osmosis, direction of fluid movement. So until this movement ceases, or this concentration will remain the same. Once the concentration remains the same in both containers, then the movement of fluid will cease. That is what happens. Then we can also talk about movement of solute particles to define osmosis. And here it is the movement of solute particles from region of higher concentration to a region of lower concentration. So you can define osmosis in either way, determine or depending upon whether you are looking at the solute aspect or the fluid aspect. If you're looking at the solute aspect, then it is the movement of solute particles from region of higher concentration to a region of lower concentration. Then you are looking at fluid or concentration aspect, then it's the movement of fluid from a region of lower concentration to a region of higher concentration. We are going to use this to understand how fluid moves within the body. So if the patient with severe FD is oliguric, that is mean that this dehydration has caused so the dehydration has caused oliguric or is causing scanty production of urine. It must be determined whether the decreased renal function is as a result of reduced renal blood flow secondary to FVD, pre-renal azothermic, or more seriously, to acute tubular necrosis due to prolonged FVD. That is the acute renal injury. Most of the time when patient goes through dehydration, we are looking at, is the kidneys affected? That is the first question we ask. So we are talking about, is the kidney involved or not? If the kidney is involved, then to what extent is the kidney involved? Is it acute? Is the kidney going to have chronic or acute injury? So anytime a patient goes through dehydration, the first organ that is considered to be of our importance is the kidney. Are the kidneys okay? Is the oliguria as a result of reduced blood flow so that we can produce adequate urine, or the kidneys have failed to work properly or to function properly? These are the two questions you ask. So we need prompt treatment of FVD. It's very imperative to prevent renal damage. We need prompt treatment. In other cases, we set the IV lines on both hands and we squeeze the fluid to go so that we restore the renal function. So prompt treatment of FVD is very imperative to prevent renal damage. So here we have the nursing process of how to manage patient with FVD. The first is the assessment. So here assessment, you're looking for the signs and symptoms of fluid volume deficit. So here is the person not taking or the person loses excessive fluid. The person is not taking adequate fluid. The person is having polyuria, because polyuria can also lead the patient to have dehydration, or the person is experiencing diarrhea or vomiting. So you are looking at all these, their causes. Then the daily body weight measurement are monitored. So my lady who asked question about whether to get the patient's weight is about the body weight measurement. Body weight measurement. If you don't take the body measurement, the weight, you will never know the exact weight of the patient. Then the vital signs will be added to confirm whatever you have for the weight. So we are saying that if FVD has fully developed, the kidneys attempt to conserve needed body fluids, leading to urinary output less than 30 mL per hour in adults. So when you have urine in this case, then the urine is considered to be concentrated, and this represents a healthy renal response. So you always have to monitor the amount of the nature of the urine coming out from the body. So as a nurse, you need to alert for a weak rapid pulse and postural hypotension. All these are signs that will alert you. If the patient is having dizziness, postural hypotension, the pulse is weak and rapid, it tells that something is really happening. So a decrease in body temperature often accompanies FVD unless there is concurrent infection. So anytime your temperature goes down, or you lose fluids, or you become dehydrated, your body temperature goes down severely, unless there is an infection. Unless there's an infection. So the skin also can be looked at, and the tank will become, so there's checked and monitored on a regular basis. So the skin turgidity, the tank fissure, or are signs that can give you a clue. In a normal person, you can pinch the skin and will immediately fall back into its normal position when released. In the person with FVD, if the skin remains or flattens more slowly after the pain is released. When the FVD is severe, the skin remains elevated for many seconds before it flattens. So the tissue tegel is best measurement by pinching the skin. So I've showed you the picture of how you can pinch the skin to check. Evaluation of the tongue tegel, which is affected by age, may not be valid than evaluation of the skin tegel. So the skin tegel is more important than the tongue tegel. So in a normal person, the tongue has one longitudinal furrow. In the person with FVD, there are additional longitudinal furrows, and the tongue is smaller because of the fluid loss. So once you would let the person pull out the tongue, the number of lines on the tongue can give you a clue. And then when the tongue is shrinked, can also give you a clue that the patient is dehydrated. The mucous membrane is also the amount of fluid there, the moisture is also decreased when you assess it. The patient may have a dry mouth, and it's an indication that you've been breathing through the mouth breathing or not. The urine concentration, we said the urine becomes very concentrated. If you use the specific gravity, will be high because of the particles suspended, and it will be above 1020. And a decreased peripheral perfusion can result in cold extremities. Because of low cardiac output, there will be low perfusion to the extremities. So a patient with relatively normal cardiovascular functions, a low central venous pressure is indicative of hypovolemia. Yeah, the cardiac output is going to be low because of low fluid in circulation. Patient with acute cardiopulmonary decompensation requires more extensive hemodynamic monitoring with a device that measures pressure in both sides of the heart. So next in diagnosis, we have FVD, and their diagnosis. We don't want to waste time. Planning and interventions are all here. So laboratory values are here for you to know the ranges, the normal ranges for both sodium, potassium, and the other electrolytes. So check and get to know the normal ranges. So evaluation, you want to know the ideal situation when you have intervened. So fluid volume excess. Any question for fluid volume deficit? We move to fluid volume excess. Yes. Yes. Unmute yourself and talk. Unmute yourself and talk. That is
Okay.
Okay.
Yes. Yeah. Okay, sir. From your previous slides, you mentioned that it can lead a FVD can lead to high body temperature. So I wanted you to explain a little further so that I can grab the concept there. Because when you were talking about the management, the nursing management, you also mentioned that it can lead to a decrease in body temperature. So I'm a little bit confused over there.
Don't pay attention to details. I said unless there's concurrent infection. If a child has infections and the temperature is high, the temperature fails to resolve when the child is dehydrated. So here, there is something in place, infection.
Okay.
The body doesn't have infection. Once you become dehydrated, the body temperature falls low unless there's an infection.
Okay. Thank you, sir.
All right. Yes, Patrick.
Sir, during the presentation, you said the causes. We can have vomiting. Can we add excessive blood loss to the causes, please?
Of course, yes, we can have. Yes. Okay. John.
Thank you, sir. Please, I want to find out whether interstitial space can also be termed as third spacing.
What space?
Third space.
Yes, it can also be referred as a third space. Yes.
Okay, thank you.
Yes. All right. Ahenewa. Ahenewa.
Yeah, hello, sir.
Yes, let's hear you.
Please, I wanted to ask, you said we should check the daily body weight of the patient. What if we get a bedridden patient who cannot stand on the weight? Is there any options that we can use to check the weight?
Yeah, there are weighing scales that you can, that even when, there are so many ways that you can check the body weight. There are so many ways. So many ways. A bedridden patient, which means cannot move out of the bed or cannot do anything. So we have a ways of checking it. Yes.
Okay, sir.
Yes. We have ways of checking this. So many ways of checking the body weight. Yeah. This is the period of asking a question. The time we are supposed to stop at 1:45, so I will not teach again. We will continue from fluid volume excess next week, God's willing, and we can move at a very high speed. So today was course introduction and a brief overview of fluid volume deficit. So I will not proceed. I'll remain here. Next week we will continue from here. So the rest is about for you to ask questions for clarifications. Williams. Yeah, William, your hand is up. Williams, unmute your microphone and talk.
Yes, sir. So I want to ask concerning the assessment. During the nursing process, you made mention of 30 mils per hour. I want to know if that is a compensatory from the kidneys to resolve the fluid loss, or that
Yes,
would be for
that,
evaluation.
if you see that, then it tells you that the patient is getting to normotensive state. The patient is coming back to normal. So at 30 mils per hour is assumed to be okay. The kidney is responding to treatment, and the kidney has started washing out the waste out. Are you with me? Yes.
Yes, please. Yes, please. Thank you so much.
Less than that, there's a severe renal deficit of fluids. So we don't want to go below that. Okay. Yes. Yes. I think Emmanuel, your hand is up. Emmanuel.
Okay,
Emmanuel.
Sir. Is on the types of FVD, that's fluid volume deficit.
Yeah.
You made mention of hyperosmolar and then isoosmolar. Yes. I was waiting to hear if we have anything of hypoosmolar.
Hypoosmolar will come under fluid volume excess. It will come under fluid volume excess. That is where we are talking about.
Okay.
So when we get there, you hear that.
Okay. All right.
Okay. Yeah. Yes. You didn't bring your name. We asked you to type your name. I saw a ding. You only brought 05 for your index number without your name. So I can't call your name because I don't know your name. Okay, so next time, add your name to your index numbers, so I can mention your name correctly. Let's hear you. Okay, you are not talking. Then, is it Janet or what? Okay, upon.
Okay, yes, sir. Please, I want to ask if fluid volume deficit is the same as dehydration.
Yes, in a way, but not always. Yes, there are things that is more or less the same, but other things are not the same. Depend upon the amount of the nature of fluid that you are losing. So the deficit can be isoosmolar or hyperosmolar, and that one we can say it is the same as dehydration, but in other way we cannot say it's the same as dehydration. Or it can be if you lose fluid like isoosmolar. In isoosmolar, you cannot say that it is the same as dehydration. Okay. Yes.
All right.
Depend upon the nature of fluid that is going out. But it is under FVD. Dehydration is under FVD, fluid volume deficit. Yes, Millicent. Up here, Millicent.
Hello.
Yes, Millicent.
Please. My question is, with the clinical manifestation, can we add sunken eyes?
Yeah, there are a lot we can add. Sunken eye, dry mouth, inelastic skin, the cheeks sunken in, the fontanelles, everything. We can add more. Yes, we can add more.
Thank you very much.
Thank you. Yeah. Esther? Yes.
Sir,
Esther,
please, I wanted to ask a question. When we were discussing, we said that when a patient has fluid volume deficit, you can give isotonic solutions. like sodium chloride, ringer's lactate.
The blood
In
expanders.
the case where a child of, let's say, 3 years is vomiting profusely, cannot take anything in, the child cannot eat, and we are giving, let's say, ringer's lactate, can the child also go into hypoglycemia because the child is not eating? In this case, I want to ask, can 50% be prepared as in using the ringer's lactate so that they can compensate for the
Oh, yes.
hypoglycemia?
We
And
can.
also,
DNS. You can have DNS, or you can mix the normal saline with the dextrose and give so that the child can get some glucose to prevent hypoglycemia. Okay. Yeah. But because we are concerned with the fluids, we don't want to bring the glucose aspect, even though it's part. But we want to know more about how the body balances fluids. But you can still raise the glucose level by using the dextrose. Okay. Yes. Hello.
Hello, sir. Please, good
Yes.
afternoon.
It is time. It's 1:46, and we need to leave the link for others to take over. So it is time. We'll continue from here next week, God's willing. Have a wonderful week. May the good Lord be with us till we meet again next week. Have a wonderful weekend. Bye-bye.
Bye.
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 Bye-bye. Bye. Bye.
Bye.
Salam, sir.
Bye-bye.
Bye.
Bye.
Bye. Bye bye.
Bye-bye.
Bye.